Well, good morning, everyone. Welcome to the first webinar hosted by the SIOP Epidemiology and Outcomes Network. We're very excited to have two wonderful speakers today. First, we will hear from Dr. Nickhill Bhakta. Dr. Bhakta is an associate member in the Department of Global Pediatric Medicine at St. Jude Children's Research Hospital. Within the St. Jude Global Program, Dr. Bhakta serves as the Regional Director of the Sub-Saharan Africa Program, where he coordinates capacity building initiatives. Additionally, as the Director of the Disease Burden and Simulation Unit, Dr. Bhakta runs an epidemiology and health economics research program focusing on global disease burden, multi-morbidity research, and cost effectiveness. Core collaborations include steering programs with colleagues at the International Agency for Research on Cancer, the Institute for Health Metrics and Evaluation, and the Concord program. His other primary implementation roles at St. Jude include leading the St. Jude Cares Global Hospital-Based Cancer Registry Network and co-directing the ARIA Guide, an adapted management guideline initiative in collaboration with SIOP. Dr. Bhakta is a native of Chattanooga, Tennessee, and earned his bachelor's degree with honors in history from Brown University, a medical degree from the University of Cincinnati College of Medicine, and master's of public health from the Harvard School of Public Health. Dr. Bhakta joined St. Jude in 2013 as a clinical fellow in pediatric hematology oncology before joining the faculty, and he currently practices clinically within the Division of Leukemia and Lymphoma. After we hear from Dr. Bhakta, we will hear a presentation on the Argentina Childhood Cancer Registry from Dr. Florencia Moreno. Dr. Moreno is the founder and director of the Argentine Pediatric Oncology Registry since 1999 in Argentina, and the coordinator of the National Program for Children and Adolescents with Cancer at the National Cancer Institute since 2016. She is a native of Argentina and received a medical degree from the University of Buenos Aires and has degrees in oncohematology and oncology, as well as a master's in clinical effectiveness and health policies. And her mission is to advance pediatric and adolescent and young adult cancer care through equitable access, early detection, and cancer registries in Argentina and worldwide. So we're very lucky to hear from them today. We look forward to learning about your work, and each speaker will have approximately 20 to 25 minutes of presentation and time for questions after their presentation, and hopefully time for discussion at the end as well. So with that, I'll hand it over to Dr. Bhakta. Thank you.
All right, thanks so much, Erin, and welcome to everybody. It's actually great to see so many familiar names on the list, and also for all of those that I owe something to, go ahead and send me an email. I apologize, just as Venkat and others can remind, we'll share, just feel free to bug me, but I'll go ahead and get started. And Erin or Venkat, could you mind just confirming again that you can see my screen?
Yes.
Okay,
Yes.
perfect. So they asked me to speak on the kind of what are and what is the role of hospital-based cancer registries within the broader childhood cancer space, as well as provide a couple of examples of how they've been implemented and why they may be useful. And so most of this, I'm sure several of you have seen in different contexts, but I think there's a couple of additional slides that might be interesting for others. And of course, it's always helpful to sometimes hear things at couple different times. So I'll kind of walk through just a general overview, and I think this will also help because when Florencia comes, she'll give a much more, I'm assuming, grounded view on population-based cancer registries and their critical importance, both just the epidemiology and policymaking. But I'll give kind of how the two interrelate, and that these are not necessarily unique, different tool sets, but really they are complementary. I'll walk through just a couple of slides on the example of what we've been developing in terms of the SJ Cares Network in collaboration with many of you already on the call. And then I'll give an example of how really one of the strengths of registries as a concept, and actually use the fever registry as an example for that. And that might be something new for you as it relates to quality improvement. And then just end with a little bit about the logistics of how these work. So Just in terms of a broad overview, I think that since I was going first, it was important to highlight why do we care about cancer registration. And again, this is something that I think many of you already would be familiar with, but maybe for some of the trainees that are on the call, uh, generally and historically, the purpose of registries are, and I think nobody would dispute, to support actions aimed at reducing cancer burden. So really, how can we how can we help and support cancer control activities in any community? And in order to do that, you need data. And that's really, I think, the primary premise of registries is giving data. The question really becomes, however, not just about what collecting the data, but how you use that data. And historically, we've talked about that in the context of population-based cancer registries. Because for decades, that has been the primary goal and premise, and really driven by the adult space. And so when you've seen historic lectures, you'll see there's two primary goals of registries that have been elucidated. The first one that it is to provide geographic and temporal trends, and the second to support etiology research. And this is where it gets a little controversial because I'm a pediatric oncologist, and I look at these two bullet points, and again, these have been in most papers, most presentations that you've seen historically. And I think the times have changed, but historically, and I would argue that from a pediatric side, of course, it's important to understand geographic and temporal trends because we know that many countries, with the cure-all package being implemented, with health service delivery being improved over time, what we do see is trends of increasing incidence that, while maybe 1% per year can be are unexplainable for reasons we don't fully understand, that the vast majority of that is due to health-seeking behaviors and overall access improvement. So sure, that's an important trend to be watching, but it's not necessarily driven by an epidemiologic cause, which is that second part. We know, again, a small amount of increase of childhood cancer is occurring in high-income countries where we have good surveillance, but but we've never been able to utilize registry data alone in order to understand etiology. And registry data really is about that phenotypic data. We don't get a lot of that tied-in genotypic data. And while folks are actually starting to do some interesting work tying in data such as pollution and other climate change related issues, it's still unlikely that after 60 or 70 years of small numbers in the childhood cancer space, et cetera, that's going to really be a driver. If you look at this from the adult side, of course, totally different story, right? Adults' geographic and temporal trends, there's huge differences. You have everything from cervical cancer, colon cancer, major numbers, so you can look at etiology, et cetera. So there's a huge dichotomization between adult cancer epidemiology and childhood cancer epidemiology. And we have to recognize that and understand how can registries support both of these. This is not to create a diminutive role for registries. It just means that we need to rethink the bullets. Because ultimately, as a childhood cancer physician, I care about obviously pediatrics, but ultimately the outcome that matters to me is survival. Thus, we need to rethink the purpose of registries that relates to children because much of the global data, very few population registries can link with survival data, at least in low and middle income countries. Even in high income countries, it's not ideal. Thus, we need to rethink these registries and think not just only about incidence, but also about the outcomes of patients over time. But of course, this becomes really complicated in the concept of broad registration. And so if you look here on your x-axis on the top, you have the childhood cancers kind of in the green, and then as they merge into what are predominantly adult cancers here in the orange. And if you think about that continuum, those cancers in green represent a very small portion, probably only 2 to 3% at most, maybe even 1 to 2% of cancers in any community, whereas the orange represent over 95% of the cancers in the given community. So if you're going to capture data, population-based registries have to capture data on everything, including in the orange zone. So that means that for the vast majority of cancers, you're not going to be able to capture a ton of depth and lots of data. And so you have to, especially if you want to capture the same data on everything, which is really an important role for general population-based cancer registries. I think you'll hear from Florencia very interesting presentations on population-based cancer registries for children, which is which augments this very nicely. But I would argue also there's an opportunity here to go deeper. If you look at that y-axis, how much data you can actually collect, this is where hospital-based cancer registries can play a role, especially because they can go deeper because there's less patients overall to collect data on. So if you think about, retinoblastoma, Wilms tumor, sometimes we get hung up on our own patient populations, but in the broader cancer space, it's a small group of patients. And so we can go deeper and capture more information on those children, information that are both in terms of their outcomes like survival, but also potential determinants that could help us understand what is the quality of services that are being delivered. And then there's protocols, and protocols are important, but protocols add additional depth of data, but really into the research realm where we don't really know what could be or cannot be actionable. Because remember, a protocol is about a research question where you're trying to advance scientific knowledge. So I often have times folks, at least historically, have said, oh, we don't need a registry. We have protocols that are open. So we're collecting data. Well, first of all, you don't have a protocol on every disease. And second of all, protocols are often collecting data for a research question, not necessarily for the community health, public health. So the ultimate reality is I can't prevent childhood cancer. It's always important I always like to remind everyone of that, even though I think in this community at SIOP, we all know this, but childhood cancer is not preventable for the vast majority. Early detection, early diagnosis, secondary prevention sometimes gets thrown around as an important concept, but it's muddied. Primary prevention is not possible. However, we can cure many children with cancer. There is long-term survival that is a possibility. But ultimately, to achieve that goal, quality of care is paramount. So where can hospital registries fit? If you think about the childhood journey, patients develop cancer, diagnosed, treated, cured, become long-term survivors. All along that train, you can get misdiagnoses, inappropriate referral, excess treatment-related mortality, what happens while treatment is going on, of course, long-term survival. And there's many data sources out there that you'll read in the literature. There's simulation models that have suggested that about 40 to 50% of children who develop cancer are misdiagnosed or not diagnosed. We have population registries that help us with the diagnosis data, as well as some population registries that can give us survival data. Cohort studies like the Childhood Cancer Survivor Study and UK CCSS and the Dutch later study, which give us long-term survival data. But then on what's happening in the hospital, what's happening with treatment, that's really where hospital-based cancer registries can be important. And that's important as we think about how do we look at what interventions, right? So how are we monitoring guidelines? How are we monitoring the quality of care that's being provided for treatment access and the referral pathways and how well they're working? Those are critical components that can only be captured if we look at this hospital-based source. And so hospital-based cancer registries really are meant to maintain data on all patients in a hospital facility, but not in a total population. So they can't report incidence. They can report frequency data, an important epidemiologic point. But really their goal is to improve the quality of care delivered at the hospital. And then report those data, very importantly, to population registries as another data source. And then population-based registries are about maintaining all of the data in a population, collecting that epidemiologic surveillance data and then tracking and monitoring incidence and survival for data for national purposes and surveillance purposes. And often people think, oh, we have to choose, but I think that's a false dichotomy. I think that these are complementary. A lot of times, if you're thinking about scale up, you may want to start with a hospital registry and then scale towards a population-based registry. But if you already have a population-based registry, implementing hospital registries will only improve the quality of the population-based registry that is there. So what is the difference between a registry and a medical record? I get this question a lot. I think colleagues often think, well, we're going to be implementing it doesn't matter what country they're in. Like, it's always in the horizon. It's always in the policy plan. We're going to have an EMR. Don't worry about it. We'll collect it. Well, remember, hospital registries are about data for decision making, whereas data for clinical care is what EMRs collect. And what do I mean by that? So first of all, hospital registries are set to a discipline, so you can have a cancer-based, hospital-based cancer registry, whereas electronic medical records need to go to a whole hospital, so that your order of magnitude and implementation is challenging. Because with hospital registries, they can be targeted investments versus systemic costs, which are huge. But then really the goal of hospital registries is to prioritize quality data by limited data entry, and it's retrospective in nature, whereas EMRs are real-time data collection, even if they're wrong. Today, I might write a note with an assessment that says I have a diagnosis, but then 3 days later, I get another test or the patient evolves and I realize I was wrong. So I have data that's in there that I'm trying to just organize all of it and try to capture everything. And then that allows a user, or in the future, maybe artificial intelligence, who knows, to come in and synthesize that information to make clinical decision making. Whereas a hospital registry is meant to be very clear, clean, quality data that can be analyzed for purposes. And so why do I keep harping on that quality point? Because we all know the old adage, garbage in is garbage out. So it doesn't matter how much data I capture. It doesn't matter how irrelevant, it doesn't matter how relevant that is. And if the data managers have lack of training, there's no cross checks, ultimately then poor decisions get made. You get poor return on investment. And the goal that we all have, which is to improve quality of care, means that less children survive. So you must collect only data that is actionable and feasible. So to give a kind of example of a real world hospital-based cancer registry network, through our network at the St. Jude Global Alliance, we've developed the SJ Cares Registry. And I think several of you are familiar with this, so I'm not going to belabor it. But what we recognized when we started in this was that there was no standard for hospital-based cancer registries. A lot of folks had Excel spreadsheets, which are not a database. Anybody who needs a database, just remember Excel is a spreadsheet, not a database. And then a lot of folks were just building their registries as a concept off of like a population, a protocol study that they had done. So they were capturing a bunch of variables that may or may not be relevant to the overall population health that they were trying to monitor and support. So what first thing we did was we standardized the variables, and it was 90% of the variables because we know that things like race and ethnicity can vary at certain sites. We also added core variables that were optimized for pediatrics and AYAs and aligned them with population registries, a very important point. And you'll hear me come back to this over and over again, is that hospital-based registries should be a core data source for population-based registries, and data sharing must occur. Multi-language support. We built an initial tool on the St. Jude clinical trial platform because we felt like any vault that we use for clinical trial data should be, as it has a level of security that we should be able to ensure to anybody. And that allowed us to put it in the cloud. We established data governance rules. I'll talk about some of this later. And then we put together three major toolkits. Data standards. They're publicly available. The website's there. Anybody can go and look through the data dictionary so you can recreate your own. And of course, that's what we want to encourage. Doesn't matter what tool you use. It's just to make sure that you're using the same data. Do training on Cure for Kids, and then a secure cloud-based tool, as well as a REDCap version, which again, I'll talk about in a minute. This just shows the I think this is actually older now, but from the summer, but you can see here there's over 40 plus hospitals around the world that are implementing or that have implemented the hospital-based cancer registry. There's a really amazing network in Brazil that have used REDCap to implement this registry as well. And Infog is planning on that. And in Ethiopia, several sites have come together and implemented this as well. So again, thinking about the data standards, it doesn't matter what tool you use. I know colleagues in Indonesia have taken on this and put this in place, and many others. So this is certainly, we're very excited to see the growing data that's starting to evolve among the global community in the hospital-based cancer registry space. So what does this registry look like in terms of where we are at and how it's growing and where we're going? And so among the 40 plus centers, you can see here, this is the cumulative accrual over time. We started collecting with the first site in September 2020. Obviously, through COVID, it was very slow to onboard, and we wanted to learn a lot as we slowly grew. But then now it's starting to exponentially continue to gain. And so we have over 20,000 patients in the hospital-based cancer registry to date. Over 190 hospitals around the world have signed data use agreements with over 40, that's a typo, entering in data. Over 50 are completed with all of their training, and we've trained at this point over 400 end users in how to be able to do this data collection. And there's an architecture that we developed that is very modular, because we recognize that these registries need to meet the level of sophistication and implementation of various hospitals around the world. So we have a core cancer registry, which we think that everyone should be using. It's kind of the very minimum data source and data set for monitoring quality outcomes. But we also recognize that many of our colleagues around the world are interested in how fever neutropenia or fever management is impacting their children, because they know that a third of children potentially in some settings have mortality due to infections. Or others have been doing EVAT or PASHA and recognize that they want to be able to ensure that they are monitoring deterioration of their patients and optimizing critical care. So we've developed or are developing discipline-based sibling registries, which allow for colleagues around the world to be able to monitor quality outcomes using registry-based principles. And again, this is where we had to think about how turn registry as a concept on its head, turn clinical trials on its head, and understand that registries are retrospective studies collecting standardized data over periods of time for the purposes of quality improvement. And with that hat on, you can start to see how these data registries in the pediatric oncology space not only can coexist, but also can be optimized so that they can share data between them, so that somebody collecting data on fever does not have to collect double data on all the cancer outcomes or determinants, but those data can be integrated. And ultimately with ARIA, again, I can't go through a talk without putting my ARIA hat on as well. We recognize that ARIA as a global guidelines tool will provide guidelines for different diseases. But any guideline needs to have a monitoring mechanism so that we make sure that we're collecting data to monitor adherence in that. And so we're working now to establish standardized data collection for each of the ARIA guidelines that are recommended to monitor for any hospital that is interested in deep dives in specific cancer subtypes. So as an example of how this is being used for quality improvement, I'm going to talk about the fever registry, for example. So if you think about differences in the intervention, so fever and neutropenia management, some things happen at home. Patient gets a fever. They arrive. They should hopefully get worked up. Blood cultures, antibiotics should be then administered. And of course, in between that, they should be registered upon arriving at the hospital so that somebody can identify that, oh, this is a patient with cancer that needs to get rapid intervention, and there needs to then be rapid or antibiotics ordered. As many of you know, that this is a very straightforward concept, but it sometimes takes hours and sometimes it will take like even a day to get all of this done, even in a hospital setting. So with the fever registry, hospitals in Central America have piloted this, and they were able to monitor how long does it take from a fever to registration. And this gives them a sense of, wow, almost nearly half of patients are taking over an hour to be able to get just from arrival to registration. And we know that, of course, for many patients, the time that it takes for them to get to the hospital can take several hours. And this is in Central America. I'm sure in your context, in many contexts, you can see it could be longer. And then from registration to antibiotic, it's over 50% take time from point A to this antibiotic administration. So if you add all of that up, it can sometimes take 8 to 12 hours from getting to the house to getting antibiotic. There would be no way to know that or to track this over time if you didn't know that data. And so the fever registry allowed folks to be able to, and this is messy because it's early data, it hasn't been cleaned, but you can see hospitals can start to see what is their baseline. What happens then when one of them implements an intervention and actually starts to see, oh, wait, we're starting to now reduce that minutes between registration and antibiotic administration. So this is registry data that is being collected, that is being used now for implementation and quality improvement. Same thing with blood cultures. You can see that different hospital sites, that each of the blood cultures before antibiotics were being captured, that it also provides an example of how different hospitals may have different needs. Hospital A has episodes with positive cultures, whereas Hospital F doesn't. And that might be because Hospital F or E has issues with the quality of their blood culture collection or something along those lines. And then, of course, it helps with understanding contaminants and other issues. And then monitoring adherence to guidelines, as I highlighted, these data are critical for those kinds of issues. And so outcomes, of course, these can let us go into secondary detailed outcomes. While in the hospital registry, we may capture that patients died because of a infection. There can be much more data in terms of the types of microbiologically identified, and that can help understand how antibiotic use and utilization can be done. And it also gives us a sense of what the types of infections are, and it gives a deeper dive and more nuanced dive into that. And so all of these data are collected by a registry, but with the purposes of rapid quality assessments and implementations that policies at hospitals can be addressed. Just very briefly, the concept of a workflow is very important for this hospital registry. It's different than a population registry. A population registry, usually you come after several days or you come after several years and come back and collect the data one time. With hospital registries, they're semi-real time. They're not truly real time, but usually on admission, we ask that hospitals try to enter in essential information and demographics, but then 3 months later, come back and enter in the diagnosis and staging data. 6 months later, come back and enter in treatments data, and then follow up yearly after that. And the purpose for that is really because we know that it takes time for diagnosis and staging in many countries to happen. So giving that delay allows to make sure that you're getting the quality and correct data. And of course, there's a number of fields, as we try to keep it to a limited number at any time point, so it doesn't burden or break any data collection per team. We've developed a cloud-based tool as well as a REDCap version. I won't go through too much detail, but just to say that we recognize that not every country or every team is able to do a cloud-based version for a variety of reasons, whereas REDCap gave us an opportunity to create a version that many could use if they needed something that was local. But of course, there were limitations in that we could actually help with a lot of the data collection, data cleaning, and data monitoring when using cloud-based. So we could essentially support those efforts as a service from St. Jude, whereas REDCap, it really required teams to develop their own expertise for reporting, for data cleaning, and all those kinds of teams. And out of that, we've been able to create data equity from that. So we collect this data, it's designated non-research, but every site signs a data use agreement with us to be able to collect their data and ensure that they own their own data. But then we also we're able to create a de-identified data warehouse. That allows for a robust opportunity for research, both for quality improvement research, but also global epidemiology research. And so for that, we have had this data bank so that any of our colleagues in the Global Alliance can generate ideas, have those reviewed, and then support publication data. We've developed educational tools. I'm just going to breeze through this. A variety that are available on Cure for Kids. Anybody can access them. All content is available in English and Spanish. There's also additional course material in Portuguese, Russian. It's over 400 users have done this as well. And we've done this for a variety of different folks, whether they have medical backgrounds, whether they do have medical backgrounds and are entering in data, or physicians as well to be able to monitor those data. We have different courses and different curricula available for each of them. All of this is free, and so just email registry@stjude.org if you're interested in getting access to this. So I'll just end off by highlighting that registries really are providing opportunities for research just on guideline performance. We think that everybody should be doing this as a hospital-based cancer registry. It's part of it's a very limited ask. It never really completes. It just requires data use agreements. But then, or at least an IRB, but that could be a retrospective, a non-research IRB determination. And then from adherence monitoring, you can have a kind of a quality improvement based study and utilize registries for that, as well as for studying implementation of new products or new tools. And then, of course, new novel therapeutics research. That's really the purview of research studies. And so this is really meant to be a part of a larger ecosystem. If you think about registries, they integrate with ARIA, as well as profile tools, which many of you are familiar with for quality improvement and packages. And so that all of this registries can become that data-driven mechanism so that we can adapt what we're doing with ultimately improving outcomes cyclically and over time. So that this is a never-ending story of quality improvement. All of these details are available online if you have any questions, and feel free to ask. And with that, I will stop.
Thank you so much, Dr. Bhakta. That was wonderful. Any questions from the audience? Feel free to unmute and say your question or put it in the chat and we can read it. And while we're waiting for a question, I'll start off with one. So given the many different contexts around the world, and I think as people interested in furthering the outcomes of these children and the research, it's always the temptation to collect more data, lots of data, and how would you go about recommending the prioritization of data collection, kind of balancing local needs and contexts and actionable data for that particular hospital versus wanting to standardize and prioritize data collected elsewhere for data sharing and pooling. What are your thoughts on that, Dr. Bhakta?
No, this is really important. And so this is where when we designed this as a scalable and modular approach. So that's and thanks for that question. So the core cancer registry, hospital-based cancer registry, we provided, and again, this wasn't developed by me or just a couple of folks. This was actually developed by a variety of hospital-based cancer registry, population-based cancer registry, as well as pediatric oncologists working collaboratively to think about what data needs to be collected as a core tumor registry form. So we created this, what is the bare minimum of a hospital-based cancer registry tool. And so that's, like I said, that's available online. You can look for them. But we also recognize that if you're interested in understanding, if you have MRD and you want to go into deeper depth about some of your ALL therapy, or if you want to look and see what's going on in terms of the time from a patient getting their interim evaluation to end of therapy evaluations to actually getting radiation for Hodgkin lymphoma, like those outcomes are important. Not every hospital is going to be able to collect or track those, but there are hospitals that do, and they see that as important for monitoring adherence to their guidelines. So we see these tools, these extensions, as optional, and you don't have to do them forever. Maybe you do that Hodgkin lymphoma one for a couple of years, have enough data from our patients that you've addressed kind of the main institutional barriers that you have, and then you move on to another, like Wilms. And so it becomes a process by which you can have iterative and over time. The same thing with fever registry or post-reg. You can't collect all of these at once, but you kind of choose where do you think that the challenges are. And so you use things like profile, or you use like these assessment tools. And when you do these assessment tools, you make priorities, and those priorities are really critical. And so that's why I highlighted, for example, the importance of how all of this integrates into that SJ Cares tool framework. Profile is how you say, okay, I've got 10 challenges in my hospital. I'm going to focus on these 3. And then you have the tools that you map to that. And then you make decisions for a period of time, and then you move on. Natasha.
Hi, Nickhill. Really fantastic work that you're doing. And I know some of the context and background to it, but I just know, with your data governance and having to enter patient information on there, I'm just wondering what your strategy has been as a group. I can just imagine the government being so protective over, having to share personal information, especially if the hospital is using the cloud-based system. So, have you experienced some resistance? What has been your strategies to overcome that? Thanks.
No, I think that's been like the number one issue that people always bring up, but it's incredibly surmountable in almost every context. So there are countries that will have very restrictive data laws. But even in those contexts, for example, in China, we were able to work through governmental ministries and systems to be able to get the appropriate regulatory approvals to be able to implement this. So first of all, there's usually a mechanism in many countries. You just have to work through it. But that being said, it requires a lot of education of administrators. It usually requires me talking to lawyers around the world about basically this. But as a community, as a global, as in the broader global sense, the concepts such as cloud computing and online data storage have moved. And what I usually explain to folks, the first thing I says is, well, do you have a bank account? And almost everybody's like, yeah, I do. I'm like, well, did you know that when you log in on your app on your phone, that's in a cloud-based environment? So what did you do when you signed up? Well, I just clicked a box. I'm like, exactly. So let's think about that now. Let's deconstruct that for health data. And so we talk about, what does encryption look like? We talk about who has access and who can actually look at the data. What are the programming firewalls that are in place? What are the protections that exist? And when you walk through all of those security measures, two-factor authentication and everything, and then you apply that to industry standards in other places that people are already using, and when you start to understand why are some of those data restrictions in place, it's because really, why did GDPR come out? It's because Google and Apple and everybody were collecting information for marketing purposes. And then what is about the public health? It's a very different construct. And so then as they have those conversations with clinicians, administrators, government officials, lawyers, usually within a few months we get to some kind of synergy. And it may be that they have to have a local red cap version, and that's why we created it. Let's not delay things or make this more complicated than it needs to be. But generally, we've seen that like I said, 190 hospitals in almost 70 countries have signed the data use agreement, which is allowing for the free sharing of data.
All right, thank you so much. I think we should move on, and hopefully there will be time at the end for further discussion. So now Florencia, I will share your slides and let's make sure
Okay,
that this.
good morning and good afternoon, everybody. Nick, your talk, it was wonderful, and so clear. So, okay, next one. Okay, I want to share with you. First of all, I very thank you to let us share our experience in Argentina. So we are very happy to be with all of you. And the first thing is that from October 2022, we are in the global initiative. Next one. Okay, Nick, you already talked about this, but I'm going to just to put in order the talk that we are going step by step. So we are talking about for the epidemiology, the registry, the national registry, the importance that they have in epidemiological monitorings, healthcare planning, policy development, evaluation of outcome, global comparison, and equality in care. So next one. Just an overview of Argentina. In Argentina, we have a 70% 5-year overall survival in childhood cancer. But in the country, we have difference in depends of the high developed index that they have. In the high, you have 73% of survival, and the low human developed index, we have 68%. So we have difference inside the country. We have around 1,358 annual cases from 0-14. We have the incidence rate that is 131 per million. And we have already 700 adolescents. We have 30 days, the median of the diagnosis, but they come from 11 days to 76 days. We have to work very hard on that. We have 211 pediatric hemato-oncology doctors that they're able to certificate oncopediatric patients. We have low treatment abandon, but we have as team, we have to work on the specific data of that information. We have 31 pediatric oncology units that they are stratificate, and we have 66% of the patients were treated in public health coverage, and we have 48% of the patients that they have to move to treat for part or total treatment. Since 2000, we have the registry. This year, we have 25 years birthday of the registry. And we have more than 41,000 cases registry. Since 2016, it was very important for Argentina that we have a national program at the National Cancer Institute that is from the Minister of Health. Since 2022, we have the law, we have the oncopediatric law, and in February, we did it very fast. We work 24 hours a day for 7 days a week to try to regulate the law that it was in February 2022. Next. So a little history about the registry. We was born in 1999. We born in a foundation, Kaleidos Foundation, and we travel all around the different units, the most important units around the country, trying to share the way that work in the registry. So we centralize the information. We develop a specific program for the registry that the foundation did it. And for us, the most important things is we did it by writing in paper at that time. So we centralized the papers and then developed the system in some hospital computers, because we have to put the program in the computer. So, but every year we develop to each unit the information that they share. Next one. Then in 2010, the National Cancer Institute, and we move to the National Cancer Institute, and we have a new system in 2014. So we keep working in the same philosophy, that we have information and give back information with the publication. Right now we are working in the 2024 publication. Next one. What I want to share with you that in the team with the program, we are 9 person working, and we have registries and navigators. That we have 4 navigators and 2 registry, that in totally there are 6 helps in different and strategic areas of the country to contribute taking care of the registry. Next one. So the system, they have information for the patient, information for the disease, that we use international codifications. We have information for the treatment, the relapse, observations, and follow-up. Next one. One thing that is very important, that each new patient that they're put it in the system, they cross before for the National Citizen Registry. So the National Citizen Registry bring the information, the basic information of the person. And that is make us sure that this person exists and where they live, and with this the document number of the document, that is the unique number of documents. So they put that information in the system automatically. Next one. We have information for treatment, that you can do it by protocol, that the protocol that we use in Argentina, or by drugs. If there is some protocol that it's not the first line or second or third line, you can also put a specific the drugs. But also you can put shots chemotherapy. It's depend of the deep that that center or that oncology wants to get on. Next one. And then here, for example, that I start that with, I said epidemiologic monitoring. Here we have the tense of mortality, that it's going down. We have the incidence rate, that it's very stable. In Argentina, we don't have increased the cancer, oncopediatric cancer. The tendency, it's stable. We can show the survival. Here at the right, you have 4 periods comparing quinquennial periods, that we can see that we start at less than 60% of survival, and now we are a little more than 70% of survival. This improve, but we have to do more, because 70% is still low survival. Next one. And here, for example, is specific for leukemia, and also we can see that the tendency of leukemia are stable, and we can know how is the age distribution. Next one. Also, we can see, for example, this is very interesting. This is comparing, this is different periods of patients, these are leukemia less than 1 year, and you can see how we improve the survivals in less than 1 year. And at the right, you can see how the whole leukemia is doing in different periods. That this is very interesting, that we can improve, but in the last decade, they're not so much improved. So we have to work in support, in clinical support patients. Next one. Also, here you can compare lymphoblastic leukemia and myeloblastic leukemia, and you can see how in different pathology, you can see different survival that sometimes they're related for change in protocol, change in interventions, that this is, it's an outcome evaluation that let you have a national view of the situation. Next one. And also you can see how these are national reports, that there are all the different jurisdictions or like states in the United States or different geographic area in the country. So you can see also the difference that in between in the same national country. Next one. And the best things that you can do with the information is disseminate and sharing the registry data. And the registry data, they can be simple data, but you can share, if you have the ability and the information, more complex data. Next one. Here you can see, we are not going to go in deep on this, but we share our Argentinian data in Concord, in international incidence of childhood cancer, and in different international and global comparisons that let you. Next one. And also, this is related with national healthcare planning. We need in Argentina to a stratificate of pediatric oncology unit. So we develop with a very, very big team, develop the self-administrative questionnaire that they have 228 questions that we did it with consensus, that they have human resource and infrastructure and equipment. And this can let you divide the centers in 4 groups, the one for diagnostics, reference, and follow-up patients, the standard units, high complexity and maximal complexity. And this, the questionnaire let you do it differently for leukemias and lymphoma, for CNS tumor, for liver and solid bone tumors, and for retinoblastoma. So the unit may be a standard for CNS tumor and maximal complexity for leukemia, because not all the units have all the same standard, have the qualities to do each or different pathologies. Next one. And this let us differentiate, for example, in leukemia, how distribute the different characteristic of the different oncology units, and for CNS tumor or solid tumor. So this help to equality in care in different areas. Next one. Also, the national policy development. So we are enhancing legal access with a digital tool for pediatric oncology. So we use the registry. We describe a novel approach where doctors can certify active treatment of patients online through the registry from the ROA. That a unique oncological credential, that it's a certificate, is generated and delivered to the patients, enabling access to the benefits of the law. Next one. So to share with you, this is very rapidly and simply, the oncologists make the certificate on the system, so we have to adapt the system, and they give you a credential that is sent to the families and to the oncology by mail. And during active treatment for the law, they have monthly financial support, license of work of the mother or father, free transportation, and scholar education and comprehensive. This is already had, but the new for the Argentina law, it's the monthly financial support and license for the father and free transportation that they have to do it, work in the area of the minister that give the money to the family. So if they don't have the credential or the certificate, they cannot be able to have that benefit. Next one. So for doing that, they have different auditories that they do it in the National Cancer Institute inside the same ROA, the registry. So they pass for different systems that they have to auditory, administrative, then doctor, and then the law to give back the credential or the certificate. And they go in by mail. Next one. So in conclusion, the importance of the existence of a national oncopediatric program that include the registry. This is, I think that it's very, very important that everyone in each country if they don't have a program, national program, or a law program that work together to the Minister of Health. ROA is the core of the National Oncopediatric Program for the implementation of the law that guaranteed comprehensive oncopediatric coverage. Innovation approach, leveraging digital technology and population registry are being developed to certify diagnosis and treatment status efficiently and access effectively the benefits of the law in Argentina. And another very important thing is that the information from the registry goes straight to the patient. So in that application, the patient have the information forever, that the diagnosis that he has. And I think that this is the first time, I don't know, I never saw that from a population registry, the information goes straight to the patient. So, and the inclusion of the credential section within the registry system improve accuracy, that reliability, and real-time patient registration. This is very new for us because always the registry going back, like 2 or 3 years back. But this law make us the registry, it's doing right now in a real time. So the registry start to move really, really fast right now. So next one. And this is the first certificate that in different provinces of the country. And this is the picture. I want to show this because when we talk the registries and the hospital basis registry, because a very important information at the ROA come from the hospital-based registry. So I want to show that we are a big team. We are all around the country working very hard, and we are a lot of pediatric oncology working, and not also just pediatric oncology. Next. And these are the team, the registry team that we are in that picture. And first of all, at the left side, I want to show that picture that it was in SIOP in Barcelona. And for me, it was very emotional, but because show how we work trying to take care for oncopediatric patients. So we are a big, big team working all together and all in the same direction, trying to help and trying to do our best for each patient, oncopediatric patient. And also, I want to thank our team that it's a fabulous and magic team working all together, doing this possible. And I'm very emotional and happy because we are 25 years of the registry. So thank you very much. And I'm very happy to share all that with all you.
Thank you so much, Florencia. This is a great real-world example of some of the principles Nickhill was just talking about. So let's open it up to questions now.
Hi, I am Dilnashin. That's amazing and very brilliant work you did. That's great work. Actually, I want to ask the challenge, the initial challenges you face in initiating or setting the registry in your country. Can you share that challenges that in the initial phase?
Yes. We have a lot in these 25 years, but I think that one of the things is try to do it visible at the politician makers. So how can show what we do. But one of the things that I learned in that all years is that it's very important to work together, because what we have to do, we do it together. I think that with everybody in each country, it's very important to try to find who is the leader, because I'm a pediatric oncology, and for me, it took me years to understand that we can do something for the country, not but such like a pediatric oncology. We have to work with who make the real decision, because who makes the real decision, they can give you more doctors, more beds, more hospitals, and so the more the challenge things is go in both direction from the pediatric oncology units, but you have to talk with your director, and your hospital director have to talk with their superior, because if you work shots in a pediatric oncology units, you are going to be by yourself for a long time. You are going to have your information, but you are not growing. So I don't want to say you are growing. The pediatric oncology in your country, they are not developed. So they need to be included in the political decision of the country. Every year in every country, the minister have money. So you must try to go there.
Thank you. That are the golden words you share. Thank you. Thank you.
So I have one quick question for you, Florencia. Given that you've now been operating for 25 years, how often during the course of that time have you revisited the registry, and what kinds of data you collect and either update or change it?
We travel all the time. We are visiting the unit, because with the program we visiting all the time. So we moving all the units contents all the time, every year. Not all every year, but we have an agenda that visiting every year. For example, now we're planning 9 trips for the next year. So, but when we visit, we work early diagnosis, we work supportive care, we work adolescent, we have to work including the adolescent in the registry, that we have to work very hard, because we don't have the completeness that we have in less than 15. So the agenda have all these topics. So we're going to visit each jurisdiction during the year. And about how are the information that we have at the registry, we are all the time that we want to move or change something, we do it by consent. For example, now we want to include abandon, but before do it, we make we work with all the oncologists to know if everybody wants to do that change in the registry. Because if you do a change, but we don't consent with everybody, nobody going to fill this information. So first of all, we want to be sure that it's important for everybody. But for example, in COVID era, we developed in the registry, on-time registry of COVID. So we have all the patients, oncologic patients with COVID in real time. And for us, it was very important because we didn't find more mortality. So we all the time, weekly, we have the statistic for the week of the COVID patients, so we can see that they are doing well. So we keep treating the patients. We stay very close by phone with the patients. So it was the registry. It's very dynamic, and we can adapt it for the different situations that we have in the country.
I see we have a raised hand.
Yeah.
Go ahead.
Yeah, my question is for Dr. Nikhil Bhakta about whether the registry contains the imaging data. And the second question would be, um, are those records pseudo-anonymized, anonymized? How does it technically works for the data sharing agreements? Thank you.
Yeah. No, so and thanks for the question. So there is no imaging data currently in the registry, but actually that's a whole separate fascinating area because there's so much happening right now with AI and imaging, that there's other tools or other ways that I think people are exploring how to utilize some of that. But for the data collection, so first of all, every hospital treats their own data collection as kind of like it has the PHI and everything in there, but only their team locally can see it. So it's very strictly user controlled. So I in St. Jude cannot get to see the hospital data that might be in Vengat's data, for example. Only the team that is in Chennai can see that. And so their team can download their own data anytime they want. It's basically a download function within the system. But then what we do is programmatically de-identify all of the PHI out of that and then put that into a pooled hospital-based cancer registry gosh, I'm losing my words today, but essentially a cohort. And so then all of the hospitals are pooled, de-identified, and then anyone who contributes data has access to that pooled data set. So that way you get access from not only to your own data, but then anybody, and then you can also do benchmarking and analyses comparatively as well. And then we have certain strict authorship rules so that anybody who proposes a study can certainly get access to the data and run it. But anytime anyone's data is used for a study from your registry, you have to have a co-author from your registry that's incorporated into the study so that there was passive and active equity rules to ensure that recognition is given for the work that's been done.
That's brilliant. So basically you're saying it would be some kind of portal of de-identified data for the collaborators, and they can choose which kind of area they want to look at, or which cancer they want to look at. So more or less like what the TCIA does for some cancer specific things. So it's maybe a bigger version of that, and like potentially like export it in the JSON format, or how does it
Different format. You can do a CSV, you can do a SAS file, you
Mm.
can do any number of different type of files
So
format.
is it only the contributors in the hospitals could be part of research? Or for example, I'm in UK and our institute is not on it, so we are basically adult tertiary care center, but can we also suggest some studies and have access to it, like what, or is only the institution who contribute the data have access to it?
Yeah, no, so the institutions have the role of being the primary kind of PI pieces, but certainly they can partner with anybody else as part of the analysis. So, but it would require then somebody from the UK having a partnership with like a Venkat or someone like that to then ensure that as
Understood.
like a co-investigator.
Understood. Thank you so much. It really helps. Thank you.
Well, we are at time. So on behalf of the SIOP Epidemiology and Outcomes Network, I'd like to thank all of you for attending. Thank you so much, Dr. Bhakta, Dr. Moreno, for sharing your work. This was really informative, and I really enjoyed it. So thank you, everyone. Have a good rest of your day, however long the day is, wherever you are in the world, and take care.
Mhm.